Thank you, Dr. Jesu and the ICS Scientific Committee. I have no disclosures. The objective of our study was to compare the efficacy and the safety of botulinumtoxina with sacral neuromodulation over a 24-month period in women with refractory urgency urinary incontinence. This shows the study design. Women were randomized to either 200 units of Botox or sacral neuromodulation. Clinical response was defined as a 50% or greater improvement in their urge incontinence episodes, and patients were allowed re-injections if they were clinically responding to onabotulinumtoxina. They were given the ability to have 2 injections, and those that clinically responded to sacral neuromodulation were allowed reprogramming. And as you can see, bladder diaries were collected at the time intervals below. The primary outcome was to measure the change from baseline in the mean number of daily urgency urinary incontinence episodes over a 24-month period. Secondary efficacy measures also included measuring the change from baseline in daily urgency urinary incontinence episodes with respect to those that became dry or had none, as well as the reduction by 75% or 50% in urgency urinary incontinence episodes. These quality of life instruments were used as well as secondary outcome measures. Adverse events that were captured during the study included measuring those that underwent clean intermittent catheterization after onabotulinumtoxina, and those InterStim patients that required either revision or removal, as well as the detection of UTIs in either group. The consort diagram here demonstrates that in both groups, over 85% completed the 24-month extension study here. These are the baseline demographics between the two groups, and as you can see, this is a severely incontinent population in both groups. The primary objective was the reduction in mean daily urgency urinary incontinence episodes, and as you can see, although there was a difference detected at 6 months, as published in the 6-month paper last year, this was not seen at 12, 18, or 24 months. And as you can see here, this shows the differences between the two groups at 6 months with respect to no UUI or a 75% reduction. With respect to quality of life measures, there were improvements seen in both groups, but it did seem to favor Botox with respect to both treatment satisfaction and treatment endorsement. With respect to re-injections, over 24 months, the median interval at this 200-unit dose was 350 days, and 75% did request re-injection, and 12% did dose reduce down to 100 units. With respect to the neuromodulation group, 58% were reprogrammed, and only 17% required 3 or more reprogrammings. There were 4 revisions as well as 12 removals. UTI was the most common adverse effect seen, and of course this was seen more commonly in the group that underwent Botox versus sacral neuromodulation. In conclusion, over a 24-month period, both 200 units of Botox as well as sacral neuromodulation had similar sustained improvement in urgency urinary incontinence episodes. Botox did, though, have greater satisfaction and treatment endorsement throughout the 24-month period. Both treatments maintained improved quality of life measures throughout the 24 months. The adverse events were low. However, the UTI rates were higher with onabotulinumtoxina. I look forward to your questions. Thank you.
Thank you for your presentation. I think we can open to discussion this paper. I've got the first question. I will assume this is a study run on idiopathic detrusor overactivity patient, right?
Correct.
What is the reason why you decided to use 200 unit and no 100 unit? And how will you explain the conclusion, your conclusion that patients with having Botox have better satisfaction?
Yes, so the 200-unit dose was chosen 5 years ago before the FDA approval of Botox, and it was chosen based on some preliminary studies from the dose-finding work. And interestingly, in that 6-month study that was published last year, we saw efficacy at this dose as well as only an 8% incidence of CIC. So that's how the 200-unit dose was chosen. With respect to the improvements in treatment endorsement and satisfaction, we're still trying to understand why there was an edge with Botox for that over Interstim. But as you look at this extension study, it seems pretty clear that both treatments do help and seem pretty equal. Yes?
Thank you.
Hi, Doug Tincello from the UK. My question was going to be what Alex has just asked you.
Yes.
Because when we did our trial, we also started with 200 units before the drug was licensed at a lower dose. So my subsidiary question to you is, you've presented the data looking at equivalent efficacy and satisfaction at the higher dose.
Right.
Do you have any information as to whether the lower dose had a different satisfaction score?
We don't, only because the number of patients that were dose reduced was so low in this study, so it wasn't really powered to study those that received 100 units.
Okay, thanks.
Great
Thank
question,
you.
thanks.
Brigitte, last question.
Just a short question. What
Yes.
was the criterion to introduce clean intermittent catheterization?
So the criteria for clean intermittent catheterization was anyone with a PVR of greater than 300, or if the PVR was greater than 200 and patients were symptomatic, they were initiated on CIC. So it's very similar to the Allergan criteria used in their qualifying studies.
Thank you.
Yes, thanks. Great, thank you very much.
Thank you.